to the impact of advancing technology. This session aims to shed light on the dilemma shaping the quality of CBC reports. Let's delve into the insightful discussions, share experiences to better understand and address the complexities faced by the lab professionals. Thank you for joining us in this webinar series conducted by Sukra Software Solutions. Now I hand it over to Dr. Srinivas to introduce both the panelists and then start off the webinar session. Thank you, Doctor.
Hello, everybody. Good evening. Is my screen visible?
Yes, doctor. It's visible, doctor.
Audible?
Audible, doctor. Please go ahead.
Okay. Good evening, everyone. At the outset, I would wish everyone a happy new year on behalf of Sukra team and the team of the pathologists over here, myself, Dr. C. N. Srinivas, Dr. Naveen, and Dr. Zubair Hasan from Bangalore. Dr. Naveen is from Chennai itself. So let me briefly introduce what's the topic for today. We all encounter complete blood count, or we call it as a CBC, which is most important test, which reflects upon the other name for this being hemogram, where we get into know what is the hemoglobin, what's the RBC, what's the WBC, and the platelets. In addition to this, there are a lot of numerical values which are generated by the machine, which is being deciphered, may not be deciphered, and the values also get into the reports. And sometimes we get into dilemma that what are these meanings of these RBC indices and the other important parameters which is released. Today we have got very important discussion, which is going to be like a small question and answer session, similar to what we ask with each other and sometimes to ourselves. And we have got two most important people who have got extensive experience in hematology. So give me a minute to introduce both the speakers. So we have here first speaker, Dr. Zubair Hasan, who has completed his MD Pathology, Diplomate of National Board, Fellow of College of American Pathologists, and he has also done an Executive Healthcare Management Program from IIM Calcutta. He is an experienced seasoned pathologist, heading the laboratory at Healthians Bengaluru. He is also Governing Council representative representing clinical pathology at CAHO, which is a consortium accreditation of healthcare organization for the year 2022-24, Bengaluru, Karnataka, India. Welcome, Dr. Zubair. On the right-hand side of your screen is his accomplishments, where he has got honors with Diplomate of National Board, Gold Medal for the Best Outgoing Student. Congratulations, Doctor. Has got publications which reflect upon his journey from a resident to that of an academician, to that of the mentor, teacher, guru, and currently heading the position of the lab head at Healthians itself. He also is interested in histopathology and as well as in cytology. He has completed his internal audit training program as per the ISO 15189, and he has also have certification in the genomic medicine and CAP inspection training itself. Welcome, Doctor, once again.
Thank you so much, sir.
We have the next speaker, who is from Chennai. His name is Dr. Navin Kumar Sivakumar. He is MD pathologist, currently heading the laboratory services at TATA 1MG Chennai. Has got more than 5 years experience as a pathologist. And most important thing, he is an enthusiastic artificial intelligence and medicine learning professional. Has got a keen interest in hematology, clinical pathology, and lab medicine. He's also interested in integrating the laboratory information management system to that of the digital pathology and help remote corners of the globe to get on to the professional practice of pathology. Welcome, Dr. Naveen.
Thank you, sir.
Okay, so to begin with, we'll take questions with respect to that of the CBC. And this set of questions is to Dr. Zubair. Zubair, the first question is, we all are confronted with CBC. Could you just enlighten about what is the CBC? what should be the standard report content for the CBC itself?
Sure, sir. I'll be sharing my screen because it's a bit echoey. Yeah.
Yeah.
I think you will have to stop sharing in that case. Otherwise.
Yeah, I'll stop it.
Yeah.
Give me a minute. Yeah, I'll stop. Yeah, done.
Yeah, so is my screen visible?
Yes, doctor.
Yeah. So CBC. So CBC, as Sir said, is a very common word, and I thought first let us see it at a layman's word, because maybe one or two people are not really into the lab field. So what does a complete blood count measure? It measures the red blood cells, white blood cells, hemoglobin, hematocrit, platelets, and a little bit of biology. We all know that RBCs carry oxygen, white blood cells fight the infection, hemoglobin is oxygen carrying protein, hematocrit is the amount of red blood cells in the blood, platelets help the blood to clot. So why do the doctors order a CBC? It's a general health checkup. Basically, for any general health checkup, it's a part of a general health checkup. It may be to diagnose a medical symptom. Any patient coming with weakness, fatigue, fever, pain, bruising, bleeding, you will go for these tests to check on a medical condition, particularly hematological disorders. You will go.
Excuse me, doctor.
Yeah.
Can you just make it slideshow completely?
I'll do that. Okay. Yeah.
Yeah, this is fine. And your audio should be a bit more loud.
All right. And then, now it's okay?
Yeah. Now it's okay, but there is a shakiness. That's it.
Shakiness, it's fine now. All right, let me be a little loud. And the next is to check on the medical treatment. So we would want to see how the patients are performing, especially when they're on chemotherapy. We would like to know if they're responding to treatment or not. So moving on to the next slide, this is a sample report of a CBC, complete blood count in my lab where I work. So what you can find is usually a CBC has a hemoglobin, a total leukocyte count, a hematocrit, a red blood cell count, then the red cell indices, which are MCV, MCH, MCHC, which I will take in the next few questions. Along with RDWCV, RDWFD, what those are, we will also discuss probably in the next questions. Menzer index, RDWI, with the differential leukocyte count. All right, and very important to mention the absolute leukocyte count. I will not dwell upon it. Right now, the question is to outline the contents of a complete blood count. So these are the usual contents of a complete blood count with the platelet count, and some people add the mean platelet volume as well. Yeah, that's about the first question. Shall I stop sharing, or sir, how do we proceed?
Can go with the second question. No issues.
Yes, sir. Can you take it up, sir?
Yeah, 1 minute.
Yeah.
I think you have to stop sharing, then only I can share.
Like that we will do. All right. Done.
Yeah. So we came to know what is the CBC and what is the standard report contents. Thanks for that, doctor. So the next question for you is, can you please explain that what are these RBC indices? What is the importance of these indices in the CBC reports? The second is that, can we rely only upon the CBC reports for the differentiation of anemia, particularly the iron deficiency anemia and thalassemia itself? So let me just I'll stop sharing the screen and you can take up your things. Yeah, go ahead, doctor.
Thank you.
Before you start, Dr. Zubair, your audio is still not clear. So just kindly kind of be a little bit loud, actually.
Loud? I will be a little loud. Yeah. Yeah, I should have put on the earphone, I think. Fine. Is it loud enough now?
Yeah, it's clear.
Okay, I'll have to shout a little bit. It's okay. I'm a teacher, so I'll do that as well. No problem.
No problem. Take your time.
Yeah. So question 2. The question 2 is, what are the red cell indices? So that's a very common question. When I use UG teaching student, I used to say the most common are mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration. So what are these? Mean corpuscular volume is the average size of a red blood cell, whereas mean corpuscular hemoglobin tells you how much of hemoglobin is there in the typical red blood cell. Whereas mean corpuscular hemoglobin concentration gives you the amount of concentration of hemoglobin in a certain amount of blood. Now, coming to the red cell distribution width, that is a little tricky one. I felt after preparing for this webinar, I realized that, there is a little diciness, there's a little confusion in everyone's mind. This shows how much of your red blood cells vary in size. We will come to that a little later. So the mean corpuscular volume is derived from the RBC histogram, and the reference range can range from 83 to 101 femtoliters. Mean corpuscular hemoglobin, 27 to 32 picograms. Mean corpuscular hemoglobin concentration is again calculated parameter, 31.5 to 34.5 gram per deciliter. The question here is the red cell indices, different formulas. My God, after going through certain papers, I realized there are quite a number of formulas which I was not aware. To be honest, what I was aware was of Menzer index, and recently we have started up reporting this Green and King index and RDWI index. But if you see, there are about 11 indices, and people have done good amount of research work on them, and more or less most of these indices rely on the same parameters. You see mean corpuscular volume and RBC, and sometimes they multiply by MCH, they divide or do this. So I'm not going to dwell on it, but this is just for information, because the scientific forum, I thought, let everyone be aware that there are a number of such indices available, and you can do quite a amount of research work on it. So what are the threshold values of these indices in differentiating iron deficiency anemia from beta thalassemia trait? So these are the indices. I will not again read them, but very common. I think most of us, which we were advised to follow as PGs, was look at the RBC count. If it's more than 5 million, you do advise for a HB electrophoresis, HPLC, to rule out a thalassemia trait. That I think should go hand in hand. Whenever RBC counts are high, see in the microscope, look for the microcytosis. Suggest. Next, we have the Menzer index, which has a cutoff value of greater than 13 for IDA, less than 13 for beta thalassemia trait, right? And we have the RBC distribution width, again greater than 14, less than 14, again sensitive for the differentiation. Then there are other indices as well. So one gets confused, which is the best indices to follow. You get confused. What do you do? So we are all confused. So I do not know the answer, but one study which has done, that study concluded that the indices of risk-circa index, I'm hearing for the first time, to be honest, this has a sensitivity of specificity of 90.9% and 100% sensitivity. And but none of them are really 100% sensitive or specific. But yeah, this is where the AI and the data analysis comes into place. I'm aware of some labs which have now started doing a lot of data analysis, and it does not cost anything. The data is already there, and you can analyze and get these answers. I'm sure Sukra software people also have some solutions for this. I'll stop my sharing of screen. Stop share. Sir, your inputs on it?
Yeah. So we were able to understand that there are 3 RBC indices, which is MCV, MCH, MCHC. With the utility of the RDW and the MCV and the RBCs, we'll be able to categorize whether they are iron deficiencies or thalassemia based upon the CBC reports to a certain extent. But I think the confirmation has to be done by peripheral smear analysis, some special stains like that of the supravital stains, and run the EDTA blood on the HPLC, as well as that of run the iron profile to differentiate between the iron deficiency anemia and the thalassemia. But since the most commonest test asked in the laboratory is CBC, can CBC help in differentiation between the iron deficiency anemia and thalassemia is often encountered. So I just thought this would be appropriate question to be answered by the practicing group. Now, the next one is like this. Give me a time. Okay. What is the clinical utility of the RDW? Which is the better one? We have 2 things in RDW, that is a red cell distribution width. We have got SD and CV. Could you explain more in detail about the RDW, doctor?
So that's a very good question. And RDW, SD, RDW, CV. So what is that? Red cell distribution width is a biomarker that quantifies the variability in the red blood cell size, pointing to the level of anisocytosis in the complete blood. The normal range of RDW, this is CV, is 11.5 to 14.5%. Now, I was baffled to see that the RDW has so much of clinical significance. Apart from hematological disorders, people have done studies and found that it is significant in trauma, predicting sepsis, to see the progression of kidney disease, coronary vascular disease, cerebrovascular accidents, cancer, pulmonary disease, endocrine disease, sepsis, age. Of course, it's a research parameter, but very valuable because it's easily available in our CBC reports. There is an article here from which, this is a courtesy from where I got this particular image. Next. So which is better, RDW-SD or CV? Before answering the question, let us understand how they are derived. So RDW-CV is a calculation based on the width of the distribution curve and the mean cell size. That means it is one standard deviation divided by the mean corpuscular volume. So let us remember that RDW-CV is dependent on the corpuscular volume. All right. Whereas RDW-SD is the actual measurement of the width of the red cell distribution curve in femtoliters at the point that is 20% above the baseline. So this gives you more true picture. It is not dependent on the mean corpuscular volume. All right. So in a way, you can say that RDW-SD has a certain advantage here, that it is actual measurement of the red blood cells and it has a unit femtoliters, right? So RDW, as I mentioned, is the deviation of red blood cell width, not the actual width, because it is a calculation, is dependent not only on the distribution curve, but also on the MCV. So there is a pitfall, or one should be aware. A homogeneous population of red cells with a narrow distribution curve and a low MCV may have an elevated RDW-CV. All right, nothing to get panicked, but just you need to remember this, that there is a narrow distribution curve, low MCV, so elevated RDW-CV can occur. Again, one more condition is there can be a heterogeneous population of red blood cells with a broad distribution curve and a high MCV. This may still have a normal RDW-CV. So you can actually use that knowledge and then we can classify anemia, which I'll come to the next slide. Having said that, RDW-SD, as I told you, is the actual measurement of width of red blood cells in femtoliters. It's kept at a cutoff of 20% above the baseline. All right. So the normal value of RDW-SD can vary in different resources. So one resource we follow is 39 to 46 femtoliters. So this is how you can utilize now. If you know about your MCV, if you know your RDW, if you know your retic count, and if you have a good clinical picture, you can actually sit down and classify the anemias and look at the clinical correlation. So again, I don't want to go in detail into the table, but this is just food for thought, that RDW is a valuable parameter. Next time you have a CBC report, when you look at the iron studies, actively look into your RDW, actively look into your MCV. If you have a retic count, very good. It will throw up some interesting observations. All right. So I will stop sharing my screen.
Yeah, quite interesting, doctor, to understand the value of the MCV and the RDW and how to get on to the differentiating type of anemias itself from the laboratory itself. That's the beauty of the automated hematology analyzers which we are using today. So just give me a moment. We will go to the next question for you. So the next question is, what's your perspective on the test requisition form containing hemoglobin TC, DC, and platelet count? Why I'm asking this particular question is that our clinicians are used to ask only the hemoglobin, total count, differential count, and the platelet count. They don't ask CBC, but now the trend is changing. But still we have some requests which are coming as hemoglobin TC, DC, and platelet count. And how do you deal with such requests? I'll just leave it to you now. Yeah.
Okay. I did not have any answer for it, actually. I was about to tell you, do not share it. I'll present the presentation. So it's a very tricky question, if you ask me, because that practice is prevalent and yet, yeah, let me just share it.
Take your time.
Yeah. Yeah, so this is the only answer I have got, curiosity, because I do not really know, but it's prevalent in hospitals, because when you work in a hospital setup, it makes sense to go only for particular tests, number one, because price sensitivity is there definitely. So that is probably one of the reasons that in hospitals, it is hemoglobin TCDC platelet count. Whereas the setup where I work in, we work in wellness centers, wellness packages. So automatically we tend to offer a complete hemogram. So first depends on the setup. Secondly, I think it's also on the camps. When you do a camp, you may want to have only a particular test, not the entire thing, because there are different modes as well. The instrument can run in a different mode. So probably that is the reason they will avoid a DC and go only for a total count or a platelet count. That is the reason, second reason. Third reason is, again, for follow-up of patients, like follow-up patient of dengue. First day, you know the hematocrit, you know the platelet count. Next day, you may not necessarily want to do a TC again. A DC may, in a small setup especially, may involve a 3-part DC. Again, a technician has to sit and do a DC. So we just say, go for a platelet count and just monitor that, going by the best practice guidelines. So probably that is the reason the TRF has these options of hemoglobin TC, DC platelet count, apart from the CBC. And apart from the hemogram, hemogram includes the complete blood count with the ESR. So these are the different facets, and some CBCs may include absolute counts as well, right? So these are my thoughts on it, but of course, sir can add much insight into it.
Yeah, that's great, doctor. That's great. So we do get requests like this, but most of the time the hematology analysis does everything. And we have the data there, but we are not transmitting it because it would have not been built. So we report only the hemoglobin TC, DC, and the platelet count, whatever has been asked. And as you rightly pointed out, the DC is both percentage and absolute numbers, what we usually give. So the last question for your session is this. Okay. What's the criteria for ideal reporting of the differential count of the WBC? And could you suggest any traceability for the same? I mean to say that there are different modalities of reporting the differential count. Few laboratories report percentage, few laboratories reports absolute number, few laboratories report both absolute number and percentage. And what is the ideal way of reporting this differential count? And do we have any guidelines on how we have to report all this? Could you enlighten us on that?
Yes, I will try my best. Yeah. So the criteria for ideal reporting of differential count in DC is, as sir said, we have to report it in differential count in the percentages as well as the absolute counts. What we follow is the absolute count we have taken from Dacey and Lewis Practical Hematology, 12th edition. I think it's a very widely popular book. But probably I did not do enough of research, so I will again go back to sir and ask him what other references are there on this particular thing of absolute counts. Because to my knowledge, I did not have probably enough, did not do probably enough research. So any other resources which are ISHTM is probably one international standard of harmonization of hematology, but I'm not very sure on this question. If sir can highlight, I'll be glad.
Okay. Dr. Naveen, you have anything to say? Dr. Naveen?
Sir, like Dr. Zubair, I don't have any additional research on this. So, but when you ask me what would be the ideal way to report a CBC, definitely it should contain absolute counts in the report, because most of the criterias and cutoffs, the clinical decision limits are based on absolute counts. So even if we are actually not reporting percentages to start with, we will definitely have to report absolute counts. Again, we'll have to see how the absolute counts are derived. Are they taken directly from the machines, or are they calculated from the percentages on the total counts? That makes a huge difference.
Okay. So I have some things which to share here. The American Society of Hematology, which are basically made with that of the clinical hematologists, have some information that the WBC has to be reported with both the percentages as well as that of the absolute numbers. So that becomes essential for them. And even the NABL specific guidelines of 112 defines that the report of the CBCs should be both having the absolute numbers as well as that of the percentages. In addition to this, the CAP checklist also says that you have to report CBCs with both absolute numbers as well as that of the percentages. Now, why this has come is that it's very important that certain times when you have leukopenia and certain times when you have got leukocytosis, the percentage may not be the absolute number what you're saying. That's the reason why they are asking us to report both the percentages and absolute count itself. If you have got a 5-part analyzer, it becomes very easy because the percentages translates itself to that of the absolute numbers with the machine. With the scatter plot, you will be able to take the inputs and you can go ahead and report it itself. So I think we had a good review of the basic primer about what is CBC, what is the ideal CBC report should contain, how to go about with the RBC indices. With the RBC indices, whether I'm able to classify it into an iron deficiency anemia or thalassemia, and how will we go about with the RDW, where we have got RDWCV and RDWSD. And the most interesting part, we landed up with the WBC, asking to ourselves that how I should report the WBC itself, whether I should include the percentages or that of the absolute numbers or both itself. And we would like to thank Dr. Zubair for pitching in for the first session. Please continue to stay here till the end of the session, Doctor. We do have some question and answers which we would like you to take up and answer for the participants. Sure. So we will take up the next set of the questions, and for this I require help of Dr. Naveen. So Dr. Naveen, just stay online. I'll just share my screen here.
Okay, sir.
Okay, fine. The question for you, Dr. Naveen, we have come to the differential now. Now, there are certain questions usually we encounter when we go for assessments, and we see that there are some weird practices, like they have a 3-part differential analyzers, but they're still giving the 5-part values without a smear review. Do we have any such practices, doctor? That is the first question. And in India, we have got eosinophilia. But eosinophilia has also been reported, and you have shared your experiences with eosinophilia on various forums. What's your perspective on these two questions, doctor? How we can handle the 3-part differential analyzer counts, and without doing a smear, we can give a differential? Have you come across any such practices? And do we have to do it? Whether it is true, ethical, please try us to help us.
So first of all, I would like to thank the opportunity from the organizers for addressing the most common dilemmas in CBC. Coming to the question per se, we will have to go back to why 3-part analyzer came into picture. So as the name indicates, 3-part differential analyzer can give the differential count from the WBCs with respect to whether it's a neutrophil and lymphocytes or it's mixed. Mixed will be comprising of basophils, eosinophils, and monocytes. So this classifications is being done in most 3-part analysis based on the size of the cells. So as we know now, this classification based on size may not be completely accurate, and there are many times in which these can miss inaccurate categorization, and there is potential to miss blast cells or atypical cells. And if there are any size variation with respect to the common cells like neutrophils, they may be wrongly classified. So it is always again mandated by organizations like CLSI to verify the manual smear and then report the differential count when we are getting any values from 3-part differential analyzer. So that's answering the first question. Coming to the second question, with respect to eosinophilia, I agree that eosinophilia is more common in tropical countries, mostly because of parasitic infections and sometimes due to other allergic conditions which we are frequently encountering now. With respect to eosinopenia, what I've observed is we have CBC count added to the part of fever packages, and most of the fever packages we get tend to have eosinopenia. So when I went into the literature and had a thorough study, I came to know that eosinopenia can occur because the eosinophils tend to fight off the infection. One, and then whenever there is a stress in the body reacts by reducing the eosinophil count, and because they are getting utilized in fighting the stress, and the body takes time to regenerate them. So this is based on my research so far. Anything you would like to add, sir?
That was a great one. So I think what you stressed was right. Whenever we have a three-part differential analyzer, it's better we see the scatter plot. And if there's a request for doing a differential count, do a peripheral smear, stain it, and do a differential count, and then release the reports. That will be very apt. And the concept of your eosinopenia and the eosinophilia, where you had told what are the reasons, are well accepted. What's your experiences with eosinophilia and drug reactions? Have you come across any of these instances of eosinophilia and drug reactions?
So, what as we are also a preventive health check concern laboratory, so we tend to get reports which have total IgE and CBC count coming together. So when I correlated high total IgE levels with respect to the high eosinophil count, most of them tend to go hand in hand. Of course, we also should remember that IgE is a very transient phenomenon. So only during the reaction, the acute phase of the allergic reaction, IgE tend to rise, and it disappears soon after that. Whereas eosinophilia tend to remain for quite some time. So whenever there is a reaction, be it with respect to drug or food or even any inhalants, um, when you do the test in the acute phase, both of these can add a value add to the actual picture when you are evaluating what is the allergens which is causing these diseases.
Good. Now, do we encounter any eosinophilia in any of the chronic leukemias or something? What's your experience on that?
So far, I have not personally encountered leukemias, but there is a condition called chronic eosinophilic leukemia. When the eosinophilia is persistent, you are advised to undergo flow cytometry to rule out clonality and specific mutations to rule out CEL.
That's great, doctor, because most of the time, whenever we see lot of eosinophils, we get excited and we try to dump it as eosinophilia just because the WBC count is normal. But I think repeatedly you are getting the same patient with eosinophilia. It's better that we call up the clinician and ask for the clinical details and work up with the flow cytometer to rule out the chronic type of leukemias where the eosinophils are very predominant, just like the basophils, what we see. Oh, that's good. So we'll move on to the next question, doctor. Could you explain more on what you mean by this extended differential count? And some of the questions sometimes we encounter is that to ourselves, not to the clinicians. The vendors usually say that this machine is able to do immunogranulocyte. And if you have that machine, should we report on this immunogranulocyte count? And we do encounter sometimes nucleated RBCs. How are you going to handle this when you are in practice?
So, coming to external differential count, first we'll categorize this into two. Let's talk about immature granulocyte count first. As you, most of the audience are very well aware, immature granulocytes are nothing but precursors to WBCs, most commonly neutrophils. So these precursors tend to come into circulation during specific conditions. Most common condition will be sepsis, otherwise called as infection. And whenever there is a infection or acute episode, the body tries to fight it off by trying to release whatever WBCs are there with it. So the brain sends signals to bone marrow. The bone marrow tries to release whatever the cells are there, and we tend to see all these precursors in the peripheral smear. So some other conditions can also give rise to these immature granulocyte count, which is otherwise one such condition is leukemia. That is nothing but a neoplasm of the blood cells itself. So even in these conditions, we tend to see immature granulocytes high in the peripheral smear. So, should labs report immature granulocyte count in a routine practice? I would say no, because these are actually based on will add a very much value when there is hospitalized patients. Say they are admitted and their blood is drawn up, and you have to see whether the patient is having severe sepsis. So immature granulocyte count can be an early indicator of sepsis, right, even before the blood culture results come to us. So in that cases, we can be pretty much sure, and maybe after drawing blood for culture, empirical antibodies can be started on that. That is one way to look at it. And even there are studies which suggest immature granulocyte count can be used in prognosis of sepsis, whether the patient is responding. If the counts gradually comes down, that means the patient is responding to the treatment, and so that can be clinically correlated with the infection. Coming to NRBC, as you all know, is a precursor to the RBCs. So they try to come into the circulation when there is a blood loss or any lysis of the blood cells which is happening in the circulation. So body tries to release the precursors into the circulation. And also whenever the bone marrow in which all the cells are produced is infiltrated with any other malignancy, they also try to push off these NRBCs into the circulation, and even in those times we get to see NRBCs in the peripheral smear, and the analyzers tend to pick it up. So I would say as a routine practice, it is not required, but definitely in special conditions, especially when the flags are there or when the count is really high, we may have to call up the clinician and ask what is the history and correlate it, and we definitely have to mention whether NRBCs are there. And when NRBCs are there, we have to also realize that we have to give a corrected WBC count, which again will be falsely elevated because wrongly these nucleated RBCs will be counted as WBCs.
Okay, that's great. So what we understood from the discussion is that the extended differential count refers to the count of the 5 mature neutrophils, eosinophils, basophils, lymphocytes, monocytes. In addition, it will be also giving us the value for the immature granulocyte as well as that of the nucleated RBCs. And the nucleated RBCs which are being reported by the hematology analyzers may be a corrected value because you told that there is a need for correction, or you have to verify in your laboratories whether the analyzers are giving you a corrected NRBCs after putting a correction factor for the WBCs and the NRBCs itself. Am I right, doctor?
Yes, sir.
Yeah. Now, what you said is right. The immature granulocyte count is an earliest marker for the sepsis, and it might indicate the infection itself. Now, do you feel that we still have the habit of asking shift to the left, or the immature granulocyte count is also same as the shift to the left, doctor? Just a question, because most of us get this again from the clinicians itself. That's why I'm asking you. What is your thinking? Does more or less it's synonymous or it's different?
So as much as I could find, immature granulocytes include promyelocytes, metamyelocytes, and myelocytes in
Okay.
most analyses. Whereas band and neutrophil will be mostly calculated under neutrophil count in most analyses. So whenever shift to left is there, so how much is the extent of the shift to left? That will include whether even promyelocytes are coming into the circulation, or only the band forms are there, or up to metamyelocytes are coming into the circulations.
Very
So
succinct, very succinct. Yeah,
this will again depend on the percentage of the cells that are there which are contributing to the left shift.
great. So do you feel that whenever we are trying to do the immature granulocyte count from the analyzers, the blasts are excluded? Am I right? The blasts
Yes,
are not coming into immunogranulocyte group because
exactly.
stressed many times saying that it starts from promyelocyte, myelocyte, and metamyelocyte. So the clarity has been given saying that blast does not come under this group of immunogranulocyte count. Correct, doctor?
Exactly, sir. So whenever there is a flag of a blast, or even when there is a shift to left, we will definitely have to look for blast, and if it is there, we'll have to mention it separately.
Good. That's nice. So we'll go to the next interesting question. What's the role of this digital imaging and reporting in a peripheral smear? And have you got any advancements in this digital imaging? Do we have any software platforms which are available in India which can integrate the numerical data, the histograms, and the digital imaging so that you can report from your mobile anywhere in any part of the world?
On a funny note, I would like to add digital reporting. We have started long back by capturing the images in mobiles and sharing it to our seniors or colleagues to ask for second opinion. So, coming to a serious note, I would classify digital reporting of a peripheral smear into two categories. One is whole slide imaging, the other is field view imaging. So there are whole slide images which can scan the entire slide and upload it into a cloud, and you can access it through a login and credential, and you can see the entire slide. What is the distribution of the cells? Where are they located? And what are all the categories of differential count you could see? What is the RBC morphology and everything? Um, Whereas coming to a field view kind of digital images, what this image analyzers will do it, they'll capture the, let's say it is classifying the RBCs. They will capture and group various RBCs into either microsites, normocytes, or macrocytes, and they'll even be able to tell you the percentage of those cells which are there in the smear. So this will help in a value add wherein this can even collaborate with the analyzer findings. So what is the MCV, whether it is correlating with the actual classification of microcytes or not. So sometimes, as we are well aware, the analyzers cannot pick up various types of red cells like target cells or even acanthocytes. So these kind of cells are very well picked up with these new age softwares, which can classify it and display it separately for us to view. This will be a very good value add in a high volume centers, specifically who are low on resources, and they will have to screen through a lot of slides and before picking and giving a valuable report. Not only that, sometimes when there are remote areas which requires a specialist contribution, if these images are there, they can be installed and the slides can be scanned and sent to a second opinion for a specialist who is elsewhere. Coming to software platforms, I have seen CellaVision being used as again field type of imaging. So it will captures and classifies the cells and group it together, giving various percentages. And whole slide images, a DSS image tech is there that can be used for scanning the entire slide and uploading, and we can use it for even EQUAS is being done using that. So that is currently my experience. And Sienna sir, you would have a lot more to add to this?
Yeah, doctor, that's a very nice inputs you have given about what I loved it is you're talking about our technical staff who captures the photos on the smartphones and pushes it, which are more better than that of the software platforms of running to lakhs itself. That's right. And what you said is right. We have two sets of the digital imaging technology where you have whole slide imaging and this. There are other platforms like 6 also, which they are having the whole slide imaging to get onto this where they can capture. Now, high volume laboratories should have agreed. But most importantly is that under-resourced lab, where you have a remote laboratory where they don't have accessibility to the pathologists, if they're having these Indian versions of the digital images, they can send a cloud link to any pathologist they like, where they can have a consultation itself. And very importantly is that what has happened is that there's a gap here. The gap is that the CBC analyzers, which are giving you the numerical data, as well as the histograms and the scatter plots, are not trying to get integrated with the peripheral smears which are happening. So the vendors are trying to bring in a middleware where they are integrating these data so that you get one link where you can see the digital peripheral smears along with the CBC data as well as that of the histograms and the scatter plots for your interpretation. There are also many other software platforms in India where they are trying to bring this bridge so that the cost of the integration becomes lesser. So whenever we look out for foreign vendors, it goes in lakhs and crores. But if it is going to be an Indian make, like we say make in India, it will be a few lakhs of rupees and you will be able to utilize that. So I think the AI and the machine learning is important, whether you are 16 or whether you're just 60 years, because that's going to rule the world where you're going to access the app-based applications from the medical reporting systems, which are again integrated to the Modi's government's Ayushman Bhav, as well as that of Ayushman software integration technology, what they're trying to say. That's great. So we'll go to the next question. We'll go to a platelet count now. So most of the time we ask for a platelet count and the lab also gives a platelet count. And suddenly one call per day, 100% I can rely upon this because one of the counts would have been only 13,000 and the clinician calls that please do a manual count. Do you accept this or how will you tackle this? Platelet count are best on manual count. So they always say this, doctor, did you do a manual count? That's the best way. So what do you feel? Whether we can go ahead and truly say that, yes, manual counts are the best, or you say that automated counts are best? That's the question. The second is that, do you consider that platelet count can be taken as an inflammatory mark? So these are for you.
So coming to the first question, I would say in my practice, when I started around 2017, I was more relying on manual counts than the machine counts because the machines which we had and the advancements which are now was not available at that time. So around that time, there are many instances in which the machine count won't be correlated, and the smears, when I see there will be giant platelets, there will be clumps which won't be actually picked up by the analyzers. But right now, many advances have come, and the analyzers themselves have been well fine-tuned to give an actual correct count in most instances. Having said that, there are again certain low-end analyzers which tend to give a very falsely low count, specifically when I with respect to giant platelets. So I would say platelet counts right now are best reported in analyzers, but definitely low counts have to be verified based on your smear review criteria of your particular lab to rule out pseudothrombocytopenia, maybe due to clumps or in case sometimes large platelets, platelet satellitism, and so on. For the second question, yes, I am seeing a lot of cases, definitely in sepsis, wherein platelet count are coming high. The other well-known instance is treatment of iron deficiency anemia as a response to increasing hemoglobin. Platelets also tend to increase. So those are my views. Srina sir, do you have anything else to add?
That's good, doctor. You are reinstating that the platelet counts are best from the analyzers if the QCs have been through, and we have to rely upon that. And most important point, what you brought out is right, the pseudothrombocytopenia, which we encounter with the clumps, what we are seeing. And if there are many, then the collection should be tackled. And if you have EDTA associated pseudothrombocytopenia, then one has to go collect it with that of the citrate tube, and then you have to analyze the platelet count so that you'll be able to give. Suppose you don't have accessibility to the citrate or a patient, I think a smear review, as you told, will be able to give us whether this is having a clumping of the platelets itself. That's beautifully explained. That's great. So we'll go to the next question. There are certain parameters like malaria, filaria, blast cells, which are critical reports. Do the consumers are being charged for this test for informing that you have malaria, you have got filaria, or you have a blast cells, which are leukemias? What's your practice pulse whenever someone sees this, though they are not being billed? How are you going to issue the reports for this?
So most of the time I have picked up, I would say, a malaria from a routine CBC than if the patient is suspecting malaria in this smear itself. But as a doctor, you are entitled to care for the patient. So I would say treat every sample as a patient. It's as though that the patient is asking what is wrong with me. So when you find something which actually the patient has not asked for, it is actually a duty to inform what is wrong, why, and whether the patient is required to consult his physician immediately or not. So informing critical reports are mandatory. There is no second thinking about it. And even if they are not charged for it, it is our duty to inform it immediately, as soon as possible, as quickly as you can verify them on smear also. But when you are informing, I would say it is better to have a history with the patient, so you'll know why, what made the patient to give the sample in the first place, and what are all the conditions in which, even if you're not anticipating, you can get these alerts.
That's great, doctor. Because most of the time, the critical alerts are not charged. So we have to inform them when we are seeing a malaria or a filaria or a blast cells so that the patients get immediate attention and the lives can be spared itself. And ethical practice do demand that we do contribute to the wellness of the patients itself. So thank you so much, Dr. Naveen, for sharing your practicing pearls, and also for Dr. Zubair Hasan. We have the next small presentation about how the software can help us in ironing out some of the nitty-gritties of reporting of this CBC reports itself. I'll be pitching in to share about few PowerPoints on that. Please bear with me for about 1 minute so that I can share the uh, uh, presentations. So these are the people today who are attending. So I have got the map where all people are seeing this webinar. So we have people from Americas as well as that of Europe, also from Middle East, and also from the SAARC and Southeast Asia itself. So that's a wonderful wow, what we can say to ourselves. And let me just go to the next PowerPoint. Sorry, I just closed that present, I think. Are you able to see the slides?
Not yet, sir.
Okay. Got it. Satish,
Yes, doctor.
do you have that PowerPoints which we can share?
1 minute. Let me kind of.
Yeah, I got it. Wait. You're able to see now?
Yes, we are able to see, sir.
Okay, 1 minute. So I'll just take about few minutes to see how the artificial intelligence can pitch in the CBC reporting itself. So the Sukra has got a product which is called as the SAIL, and which helps in making sure that the artificial intelligence has been put into practice itself. Most importantly, it is able to get us the numeric values, the digital imaging, as well as the histograms, as well as that of the scatter plots. And it will be easy for any of the laboratories, 24 hours, they can go ahead and use this for the computational methodologies for the digital imaging, including histopathology and imaging from the cytology also. Anyhow, we'll just see how the product goes. So the SAIL has got all this like pre-analytical interferences or expired analyte calibrations, QC bracketing, critical results, abnormal results, delta checks, and clinical decision supports, which are all actually important in our laboratory practice itself. And how does they help in CBC reports? So if you take the software, which is a product of the Sukra, they have got data like this on your screen, which helps us in the clinical decision support system. So they have got the RBCs and the RBC indices, gives you a bold ups and lows, as well as it helps us in saying what is the picture problem over here, which says that microcytosis with heterocytosis, even without seeing the peripheral smear. It's not that this is reliable, but at least it sensitizes the reviewer before signing this out itself. So here we have one more case where you have got an interpretive remarks. This is again by the artificial intelligence and the clinical decision support system, where it says that microcytosis with erythrocytosis is evident. Suggested microscopic examination and a hemoglobinopathy screen. As we said, we have to screen for both the RDWs as well as that of the MCVs itself to differentiate between the iron deficiency anemia and the thalassemias itself. So here you have got the MCV to be low, then RBC being high, though the hemoglobin is around 13.1, and they use a clinical decision support system algorithms based upon the international guidelines. It's not that the data board and artificial intelligence has been done like that. It's been having a traceability to that of the international guidelines also. Now we have got one more case where the WBC count is very high with neutrophilia. So if you see here, the WBC count is high, which shows that you have an arrow mark which says that it is high. Neutrophils, absolute neutrophil count being high, and differential count showing the lymphocytes to be low. And it indicates also that there is a leukocytosis with neutrophilia. And let's see the interpretive remark. It says very clearly that neutrophilia is evident, suggested microscopic examination for the confirmation. So the softwares which are available in India are able to utilize the artificial intelligence in the pathology practice, and the laboratory can also utilize these clinical decision support systems which are based upon the artificial intelligence dashboards which are made. This can also be customized to the customer, and then we can go ahead with the utility of the software itself. So you have one more case where you have got a low hemoglobin. Look here, you have a low hemoglobin here, then 11.2, RBC is low, then PCB is also low, the indices are there, and you have got a normochromic normocytic RBCs with the low hemoglobin, and anyone can guess that it could be a normocytic normochromic anemia, where you can have interpretation with that of the clinical chemistry parameters also. So you have got certain indicators visually also, like if you see here on the extreme right-hand side, you have got turnaround time, whether it is upkept, and you have got overall status also, you have got circles, which indicates that this is neutral, has got some abnormality, high values or a low values itself. And you have got the differential count in one of the cases to be having a high lymphocytes over here. So you have a WBC counts with neutrophilia. Sorry, neutrophilia you have got. And when you look into it, you also get neutropenia, which is evident in one of the cases, which suggested a microscopic examination itself. So friends, I think I'll stop because we have some questions. So let me attend to the questions also. And these are the people who have been attending here. And let me go to the questions. So we have a question and answers. So could someone see the question and answers session box there? And you can answer them as you feel. Dr. Zubair or Dr. Navin, you are able to see the questions?
Yes, I can see the questions.
Okay, if you feel that you'll be able to answer, you can take it up and answer. Yourself and Naveen can
I will
help.
take this question, let Dr. Naveen answer, because they pertain to his session, I think.
Go ahead, man.
Yeah. First is, how significant is it to report reference ranges with the absolute reference ranges? We should not provide percentage reference ranges in the report, is the question. So he's asking about the significance of reference ranges with absolute reference ranges.
Okay.
If I'm understanding the question correctly, is it with respect to the differential count?
Yes, I think.
Reference ranges?
Yes, yes.
Yeah. So we have many references, specifically with DAISY, which has given age-wise reference ranges for absolute counts. And recently, we also had a issue with respect to what to give in lower age groups whenever we are reporting percentages in WBC. So we went through the literature. We had a very detailed activity. My team and colleagues were very thorough, and we came up with an article, and we were able to get even age-specific reference ranges in percentages for most populations. But as I said initially, most of the clinical decision limits are based on absolute counts. So it is important that we give reference ranges for absolute counts. And it would be very great if we can have those reference ranges defined for this, for one's particular lab and the population which we are dealing with.
Okay. Dr. Zubair, you have any other questions in the question box?
Yeah, the next question is, hi sir, how to report if multiple platelet clumps are seen in ATTA?
Yeah, you would like to take it? Simple.
Yeah, it's a dilemma actually, because what to do. So let's say I have a thumb rule. First is, if I find extensive platelet clumps, so ideally we used to say, platelet clumps seen and don't give a value, and advised for repeat testing on a heparinized sample. That is the best way to do. But sometimes in practice it's not possible. Then what I do is, yeah, it could be anywhere. Some clinics expect an accurate value. So 1.5 lakhs, we leave it. Sometimes we do that. I don't know if it's correct or not, but we just leave it at 1.5 lakhs. Or sometimes I just leave it at 1.4 lakhs, saying it is just about okay. Aisa. But sometimes what happens is that it's a low count and occasional clumps are seen. So first thing is we have to verify the tube and see whether they are fibrin clots or not. That's very important to do. Second thing, if occasional clumps are there, I write a remark, occasional platelet clumps seen, but I do not change the value if there's one or two clumps are there, because you never know. It may be a 10,000 platelet count with occasional platelet clumps. It's a bit tricky if you ask me. I think everyone has different protocols, so others can share their.
Naveen, how do you tackle when you see platelet clumps?
So this is the first question which I asked when I started seeing peripheral smear.
Okay.
As soon as I passed out of college and we had the responsibility of reporting with our name on, how will you take the blame? So during my practice, I came into terms that when we are seeing clumps, definitely we have to mention that on the smear so that the clinician who is treating the patient will know whether the count which you are getting is completely free or if there are any interferences which can interfere with it. And if, as Dr. Zubair said, if there are very few clumps, give the mission count value and mention the same comments that occasional clumps is seen. So I tend to have an approach of based on the clinical decision limits. So if we are seeing clumps and if they are significant, I report it by giving greater than 1,50,000. Many platelet counts seen. Exact count is reporting exact count is not possible due to the presence of clumps. Always advise repeat sample in citrate if clinically indicated. That is one way to legally free legally be free if something happens. If there is a follow-up and if the patient is definitely coming and giving you at that time, if you are seeing clumps and if they are affecting the clinical decision limit, it is always best to get a repeat sample and report it so that the decision can be made.
Okay.
Your thoughts, sir?
No, yeah, that's right, whatever we are doing it. But I think we have to disclose somewhere that we had seen a platelet clumps so that people will be able to understand. So since we are already outshooting the time, I think we'll take only one more question. And I think we have one question here, like, again, it has flashed that which one will you take, the RTW, SD or CV? I think it has already been dealt. So we'll not go with the RTW, SD or CV. But for all practical purpose, it has been discussed. And let us go to the last question for the day. How will you analyze the lipemic sample and as it interferes with the hemoglobin value? Will you be asking for a fasting sample for the CBC work in such case, or will you use any lipemic plasma replacement methods itself? So I will answer this. So whenever we have a lipemic sample, the first value to be affected is usually the MCHC. So MCHC being a sensitive marker to the lipemia, it increases, it will be more than 37. And that will be an indicator that it's the lipemic sample. Yes, of course, it does not interfere with the hemoglobin value because the machines are using a separate technology for the hemoglobin estimation itself. The values which are usually affected will be the indices as well as that of the RBC counts. So if you are having doubts and you are not confident about reporting on this lipemic sample where you have got all these abnormal values, then I think fasting sample you can ask for. Plasma replacement, yes, you can go ahead if the sample is not going to be given and you are in a remote place, you are in a peripheral lab or a central lab, sample is coming from somewhere else, then you can go for the plasma replacement and then you can run the samples and give it. But once again, I'm saying the values of the hemoglobin is usually not altered because the technology for the measurement of the hemoglobin is different. It is not going into impedance. It is not going into any of the flow cytometers. The counts which may be affected will be the RBC, WBC, and the platelet count itself. So I think with this, I'll stop. The other questions, I think Sukra can compile and send it, and we can review this as a PDF and send it to all the people who are being the attendees itself. So to conclude this session on the CBC, where we have dilemmas in practice, we had a good session of understanding how the CBC report should go, utility of the RTW, how the DC should be given, and how the values of the eosinophilia and the eosinophilia matters, and how we are going to tackle up with the digital imaging, whether it is helpful, and also on the critical reporting itself. We also analyze some of the questions from the participants about the lipemic sample, the RDW-SV, which we had already discussed, and also something about the platelet clumps. So with this, I would thank everyone, most importantly, the faculty, Dr. Naveen and Dr. Zubair, for taking their time on a weekend to spend some time with us to share their knowledge. We are very much grateful to you, both of you, and also to Sukra, who partnered to host this, who were helping us in giving us the digital platform for making sure that the knowledge penetrates to all of us. Thank you so much. And if you have anything, Dr. Naveen, you can hear. And if you have anything, Dr. Zubair, you can hear before we conclude.
Thank you for having us here, sir. I thoroughly enjoyed it. It was a learning session for me as well.
Okay. Thank you, Dr. Naveen.
I completely agree with Dr. Zubair on this. So it was a great learning opportunity for me. Even whatever I could not know, I came to know a lot about it through Dr. Zubair and Dr. CNS. Thanks for the opportunity, Socrates.
Thank you. Satish Kumar, please take.
Thank you. Thank you, all the participants. Thank you, the faculty, Dr. Srinivas, the moderator. So we are very happy that we have had a very great attendance today. Almost 66 participants were actually there throughout the webinar. So as we conclude, let's carry these newfound insights, fostering innovation and improvement in our respective practices. And the active participation of all the participants has been the heartbeat of this webinar. And we look forward to all future collaborations until next time. Thank you, everybody. Stay inspired.
Thank you.